go through our algorithm in patients that we're considering to put on VA ECMO. So these are kind of the mean and median characteristics in that population. So generally younger age, lower BMI, less than 24 hours from shock onset to ECMO interval, high levels of inotropic support. They had very high APS-3 scores and SOFA scores. Lactate on average was about 8 at time of initiation. Oxygenation was pretty dismal with PF ratios on average about 87. And then the rest kind of notes that they were receiving, appropriate other therapies in terms of low tidal volume ventilation, 6.4 mLs per kg, PEEPA 10, plateau 26, and then obviously low cardiac index and high CVP. So this study showed basically a 70% survival with complete recovery of myocardial function. So this kind of goes at the time of implantation, explantation, and then long-term follow-up. So, pretty good results overall. And then when you're looking at the quality of life scores, they were actually comparable to those who suffer MI or require hemodialysis. Now, depending on, your personal views and beliefs, those are not great quality of life measures, but nonetheless, pretty good concerning everything that these patients would have gone through with the VA ECMO and prolonged hospital course. Now, what about VA ECMO for septic cardiomyopathy? VA ECMO for septic cardiomyopathy. So this was another small study, 12 patients, median of 4 days. 5 patients actually had a cardiac arrest prior to initiation. And their median left ejection fraction was about 16.25%. And with a median PF ratio of 9 kPAs. The survival rate to hospital discharge for VA ECMO in this scenario was also 75%, so pretty substantial results. Again, small study, but pretty good overall. So the real question is we need more data, right? And that's where the paper that we are going to dive into today comes along. So VA ECMO oxygenation to rescue sepsis-induced cardiogenic shock was a retrospective multi-center international cohort study that was propensity matched and looked at about 10 years comparing 82 patients receiving VA ECMO for sepsis-induced cardiogenic shock to 130 controls who did not receive VA ECMO. Now, going through the population again, slightly different than the initial study they did with 14 patients, but septic shock had to be identified as the main reason for cardiovascular dysfunction. It did not exclude those with existing myocardial dysfunction. The total N, if you look at the appendix, was only 4, however, and they really had mild reductions in their left ventricle, somewhere on the order of like between 40 and 50% realistically. So still pretty good overall. They had to have severe myocardial dysfunction and end organ malperfusion despite optimized fluid resuscitation and high dose of inotropes and vasopressors. So again, ejection fraction less than 35, which was a little bit higher. Cardiac index less than 3 liters per minute, which is a little bit higher. Lactate greater than 4 millimoles per liter, and an inotrope score greater than 75 mics per kg per minute. So that was combining doses of essentially epinephrine, Levophed, as well as dopamine. Now, the data for controls was collected from 3 databases that provided daily monitoring of patients' hemodynamic status, and those are all reviewed in the appendix. And they basically had to meet severity criteria within the first 4 days after the occurrence of sepsis. And this was largely because in the actual study population, all the patients were basically put on VA ECMO within that time frame. In terms of exclusion, not as vigorous as the previous study. So septic shock with preserved cardiac index was a major one. They couldn't have severe underlying conditions with life expectancy less than a year, prolonged cardiac arrest again, and then irreversible neuropathology. And then obviously age less than 18, they excluded from this population as well. In terms of the procedures, so they monitored hemodynamics via PA catheter, echo, or pulse contour analysis. After initiation of VA ECMO, they had the pump speed somewhere between 3.5 and 5 liters per minute. They used heparin universally for anticoagulation, and the patients were transitioned to VV ECMO if respiratory failure persisted during VA ECMO weaning, which we'll kind of talk about a little bit later. In terms of the outcomes, the primary outcome was survival at 90 days. Secondary outcomes were the rate of decrease in inotrope score, rate of lactate clearance, hospital and one-year outcomes in patients treated with ECMO, and then healthcare related quality of life, anxiety, depression, and PTSD at 1 year post-discharge. So this is kind of just a flow chart looking at how they came up with their study population. So essentially they screened 3,000 VA ECMO patients at 5 centers, and then excluded those with preserved EF, included eventually 82 with severe myocardial dysfunction before implantation. And then these are the 3 studies that they drew their control group from. So the sepsis spam cohort, DSSA cohort, and OSHA cohort. Now, looking at the internal validity for this population, so were the patients closely matched? So they used a very complicated propensity weighted scoring analysis in order to kind of get the population pretty close overall. Despite their best efforts, obviously there were some differences between the groups. So differences in population of male sex, the source of infection in the ECMO group was primarily lung. They also had lower pH, lower EFs, and lower PF ratios in the ECMO population. So that's even after propensity matching. And then if you look at the baseline population, the most notable thing is that the ECMO group is obviously much sicker. So let's dive into the results a little bit. So how large or precise was the treatment effect? So we're looking at the essentially the probability of survival at 90 days. So in both the adjusted and the unadjusted survival curves, there was markedly higher survival in those that received ECMO compared to the control groups from the other databases, basically 60 versus 25%, with a relative risk of about 0.54. The difference in survival persisted after propensity score matching, as I had mentioned. And then limiting the analysis to patients included during the first 24 hours of sepsis or excluding patients dying early in 24 hours led to comparable results. And this was even after adjusting for site of infection, year of inclusion, time of inclusion after onset of sepsis. So other results, looking at kind of some of the secondary outcomes, so evolution of inotrope score, they had a more rapid decrease in vasopressor and inotropic support requirements. And then clearance of lactate was also believed markedly better in the patients receiving ECMO within the first couple of days, tend to kind of trend out the longer they were on the ECMO unit. Now, this is just kind of a table looking at the characteristics between the survivors versus non-survivors. So obviously, the survivors would be cannulated from ECMO. Some of the things to highlight were the SOFA scores in both the survivors and non-survivors. Survivors were actually a little bit less sick than the non-survivors at day 3, 7, and 15. They had longer durations of mechanical ventilation, as well as longer ICU longer ICU and hospital stays with better ICU survival. With regards to the complications, they were pretty comparable between survivors and non-survivors, but it's important to note that there were about a total of 35 related complications, with 43% of patients experienced them. Some of these patients had critical limb ischemia requiring amputation as well. In terms of the other outcomes, so the 1 year health-related quality of life was obtained for 32 of these patients, and they actually only reported mild impairment in physical activities, highly preserved mental and social conditions. Their short form 36 component scores, again, is similar to the previous retrospective smaller study, were similar to those reported for patients on chronic dialysis or after MI at 1 year. And then anxiety, depression, and post-traumatic stress were reported by 8, 5, and 2 of the 32 patients, respectively. So what about our external validity? Is the treatment reasonable? So previous studies have shown mortality rates greater than 90% in patients with inotrope scores higher than 100 mites per kg per minute. So VA ECMO could halt the vicious cycle leading to irreversible multiple organ failure by restoring perfusion to vital organs by allowing a rapid decrease in the dose of catecholamines. VA ECMO might be able to reverse the dismal course of cardiogenic shock in patients with acute MI, a situation that shares many pathophysiological features. So overall, it does make sense to try this in select populations. Now, is it generalizable? So I put this picture here because, you know, there's very few patients in our medical ICU that would probably meet the appropriate selection criteria. You know, sometimes walking into that unit, you're just walking into a burning fire of very, very sick, chronically ill patients. With regards to some of the takeaways and considerations, so it could be used and could be associated with improved survival in patients with sepsis-induced refractory cardiogenic shock compared with controls not supported with ECMO. However, very careful consideration needs to go into the selection criteria. It's definitely not generalizable to all patients with refractory septic shock, as some of these smaller studies have shown with the dismal and really should only be used in those with a significant cardiogenic component to their shock. Likely needs to be considered in a younger population, likely healthier at baseline with BMI considerations. Unfortunately, we don't have a great deal of data on the pre-morbid conditions in this population from the study, and was not included in the appendix either. What about our post-cardiac arrest patients? Should we still be considering those, particularly those with post-prolonged cardiac arrest? And then do we need to consider the etiology of sepsis? So, you know, a greater proportion of these patients were septic shock due to pneumonia as opposed to other etiologies, and does that actually play a role? Other considerations, you know, it's a costly therapy. It's expensive, labor intensive, and there's limited availability, and really needs to be performed at centers of expertise. And ultimately, we need a lot more evidence. So randomized control trials are nearly impossible in this setting. Some other things, you know, to kind of consider, what dose of vasopressor should we really be considering via ECMO in these patients with sepsis-induced cardiogenic shock? Should we be using VAV or hybrid models of ECMO, given that a high percentage of patients that actually were weaned from VA ECMO went on to require VV ECMO? So I think I was on the order of 32 patients, 40% or something of the survivors ended up requiring VV ECMO as well. What about those patients that had delayed deterioration? So, you know, patient may come down, they're a little sick, requiring a little bit of vasopressor support. What about the ones that, you know, 5 or 6 days into their ICU course suddenly decompensate? Could we still be considering it in those cases after they develop renal dysfunction and you know, shock liver and things along those lines? And then again, you know, baseline characteristics, what types of things do we need to really kind of consider? So I wanted to give a special thanks out to, again, everybody that allowed me to participate in this, as well as everybody that participated in our ECMO specialist course. I don't think we can thank you enough as a fellowship group for the time and energy you guys put into that, and really was a great educational experience, so thanks again. Here's the references. I can send this whole PowerPoint out if everybody's interested in looking at these things. And then now I'll kind of leave it to open discussion.
Great, thank you. Oh, sorry, I was going to say thank you so much, Sam. That was a fantastic first overview of the general topic and a great sort of deep dive into the article itself. But yeah, I was actually going to ask Dr. Duggal if he could share with us kind of his thoughts about the whole situation as well.
Yeah, absolutely. Can you guys hear me? Okay. So I think the question, like whenever we have a study like this that comes out, the first question really becomes, how is it going to change our practice, right? Like, so the first question we have to think about, and then I think Sam did a really good job in terms of talking about the generalizability and external validation, is how were these patients really selected? And you know, do they really fit the bill for a lot of the septic patients that we really see? So an interesting thing is that, you know, they were very liberal in terms of what their inclusion criteria were, which is not very consistent with the first study that they published. The initial study that Sam presented, which came out about like 4 or 5 years ago, really showed that the signal was in patients that had a very low ejection fraction, and then those were the patients that really kind of seemed to benefit from this. but for them to include a much broader population was an interesting thing. But of interest is, if Sam, do you want to go to the table 1
Sure.
of the study?
So right here.
Yep. So if you look right here, like, the patients who did receive the ECMO, if you look at their ejection fractions, that's about 17%, right? With a confidence interval of about 7. So this is much lower than what they had kind of like put in as a inclusion criteria. With if you look at the cardiac index of 1.5, that's something that we need to be very mindful of. So this is not, the usual septic patients who are hyperdynamic and kind of chugging away, like who were included and analyzed in this study population. And that's something that we just need to be extremely mindful of as we think about like whether like we're going to be thinking about VA ECMO for these patients. I think the other big question here is that as they looked at these patients, there was a lot of close monitoring in terms of both PA catheters and serial echoes. Like in terms of deciding how things are being in terms of them deciding about putting these patients on a VA circuit. I think the biggest distinction that we have to make is that people who don't have sepsis-induced cardiomyopathy associated with the septic shock are in such a profound vasoplegic state that they really would be horrible candidates for being placed on the circuit. And then we've seen that in our practice too, where we have placed patients who were hyperdynamic. And this is initially when we were kind of like figuring things out. And then those patients just don't do well because the overall support system is just not there. And it's usually seen by the fact that their vasoplegic shock really is going to cause them to die in a much faster fashion. And then if you look at the initial studies that, like when we look at the survivors versus non-survivors, most of the non-survivors died within 26 hours. And I think that's extremely important for us to understand. As we talk about this, everyone understands like the propensity weighted patients and the ASD that's in the last column. That's something that you guys should be aware of. So what happens is that once we do a propensity matched analysis, because you have artificially selected patients now, getting a p-value is not good enough, because if you get a p-value, you're going to have a potentially erroneous result, because you're self-selecting your patients by putting like a propensity weighted image. So the recommendation for that is that you do adjusted standard deviation, which basically shows how far apart the two groups are. An interesting thing is like, the things that we are interested in, especially like the ejection fraction, is still significantly apart, like in terms of them selecting this, which is interesting, because what I would have expected was, because they've not really lost any of their patients when they do the propensity match analysis, you usually expect to lose a bunch of patients. So what you really would be interested in seeing is that once you do adjust them a little bit, perhaps with more stricter criteria, what is the difference in mortality? Because it might be more pronounced in that situation. It was interesting that they chose to keep their cohort exactly the way it is. Sam, do you want to look at the outcomes real quick once again?
Sure.
The next one, like where they talk about the long-term outcomes and the complications.
Oh yeah. Right.
And Sam mentioned this, but I think it's very important for us to really think about this too, that, amongst the survivors, like, from the 49 people, there were 11 patients who underwent major amputations. And that's an aspect that we have to be very mindful of as we are thinking about this, because, as we make these decisions, like, these are people who are going to be very sick, who are going to have very prolonged courses. and are going to be left with significant issues after we've put them on. So that is an aspect that needs to be very closely looked at as you're looking at your patient selection. And I think that's where age and other comorbidities do come into play, because this is going to be a really long haul. And the other big factor here is that if we look at the duration of mechanical ventilation for these patients, we are looking at a duration of 34 days for the survivors. So, and then like Sam said, about 30 of them got changed to a VV circuit. So once you have addressed that initial septic cardiomyopathy, which once it starts recovering, it's not going to be that these patients are just going to be getting better right away. This is going to be something that's going to require a multidisciplinary team and a thought process where you really start thinking about things in terms of what your next steps are going to be. And I think one thing that we should discuss today is that as we think about these patients, are hybrid circuits better than VA circuits, especially that a lot of these patients do come in with pulmonary sepsis. So if we look at the vast majority of patients who were in the Ecmo arm, there's a huge percentage that comes from a pulmonary source. So that's something that always needs to be kind of thought about as we kind of think about these patients. A question that I think we should think about again is that a lot of these patients are being placed very early on in their disease process. So what happens to patients that are perhaps having a prolonged hospitalization, or patients who have had a smoldering sepsis that all of a sudden becomes pretty significant? I think those are both cohorts that we know that their outcomes are pretty dismal at baseline. And I think translating these results and then really putting them on that cohort of patients perhaps might not be the right thing. And we need to be very mindful that that these patients with delayed sepsis or prolonged hospitalizations most likely would act very differently as we make considerations for putting them on a VA circuit. I think those were the key points that I really wanted to discuss about this, and I think let's open it up and see what everyone else thinks and if there's questions.
No, I think you brought up some fantastic points, Abhi, and I was kind of a little bit intrigued by this patient cohort and also the way that they were cannulated for ECLS. When we think about sepsis, as you mentioned it, you think this distributive shock, so they're pumping along, they need high amounts of flow to keep up with them, and then they also happen to have cardiomyopathy. When I look back through here, all of the patients were cannulated except for a couple initially femoral VA ECMO with flows between 3.5 and 5 liters, which to me that doesn't sound like a septic patient that we would typically see. And so the fact that they were able to be supported by that particular configuration as early on makes me feel like this was more of a cardiomyopathy and less of a septic kind of picture. So yeah, I was kind of curious, what Penny or some of the other cardiology oriented folks kind of thought about that.
Yeah, I can take that a little bit, Alex. I have to say I'm not impressed by the study at all in terms of applicability. I think what it does for me is just, begins to beg the question, who's the appropriate patient? And thinking about our patient selection. And obviously, as Sam started with a history of a 27-year-old, am I going to give that guy a shot? I think looking at the patient population, if you just say sepsis, cardiomyopathy, it needs to be differentiated better. And I think that needs to come with initial hemodynamic characterization of the patient. So what I would want to see in a group of patients, what I'm deciding about what the appropriate support is whether or not they've been differentiated with a Swan-Ganz catheter. I think that's gold standard for me. So I want to see what their appropriate filling is, and then I want to see their inadequacy based on that. And then in thinking of sepsis, do I think that this is a patient that I can get source control on? So has the standard of care been performed? Have they received antibiotics? If they have, gangrene, has it been cut off? So all of those things before I actually think about support. And then the question of what's the adequate amount of support. And I think here when we start talking about hybrid systems and VAV, part of it is us choosing the wrong thing off the hop. So is my patient not receiving adequate resuscitation from the circuit because I failed to recognize that they're in profound pulmonary edema in addition to their cardiogenic shock? Or, is that truly infection on top of it and they have some component of ARDS that they need a VV circuit? So I feel it's a very muddy kind of cloudy thing to try and piecemeal these patients into categories. So I think this is where, you make the argument for the multidisciplinary team to start thinking about how do I consider all of these factors at once.
I think those are all, fantastic points. And I was thinking along the same lines, because you see a patient and kind of in your initial assessment, is that a patient who's, for example, pulmonary edema is secondary to, sepsis, ARDS, or is that heart failure? And that has a huge impact on, are they VA versus, hybrid VVA kind of candidates? And just as you alluded to, sometimes you don't necessarily know, and you convert because you maybe either guessed wrong or the physiology takes you that way. So I 100% agree with the need to have as much good information up front, Swan-Ganz catheter, things like that, and a multidisciplinary approach to make sure that your first shot really is your best shot.
I see Jaime there in Florida. I'm not sure if you have anything that you'd like to add.
Hi guys, that was wonderful. Thanks for having us. And I agree with pretty much everything that has been said. I think that the question here is semantics and profiling, and how we profile also matters. I've been at La Pitié and I spent some time with Alan Combs and the authors of this paper, and they, for example, the way of profiling is very different. They profile heavily on clinical and imaging grounds, and barely as a, almost I would say, last resource PA catheter. So they do have incomplete hemodynamic assessment, as you can see in this study. There's no full profiling. And to tease out this question, whether it's predominant cardiac dysfunction or predominant vasodilatory distributed shock, I think you probably need, as mentioned, an interdisciplinary team that is able to profile granularly with the clinical context, imaging, and invasive hemodynamics. One of the things that takes me back to my days in Massachusetts, where we didn't have a lot of AMCS in a community hospital, we'll see a lot of patients that will die with this diagnosis. But clearly, as mentioned by Abby, with a hyperdynamic state, and yeah, I mean, I think that cohort is not represented in this study. So I'm a little bit surprised that these made it all the way through Lancet, to be honest. I think that it just begs the question of how open this space for profiling, for enterprise, registries and interdisciplinary conversations for decision making.
Hey, this is James. I just wanted to add that, Abby, I'm glad you brought up the amputations issue, because not only were there a significant number of patients that required amputations from the combination of the disease and the treatment, but I think they cited several that had multiple limb amputations. I think there were several, at least 2 or 3 that had all 4 limbs amputated. They mentioned that briefly in the text. And I think that if ECMO therapy is going to have a place in this, then we need an improvement in the overall treatment of sepsis, because to have a number of individuals with 4 limb amputations does really not qualify this as a good treatment.
I agree. I think one of the interesting things is when we do look at these 1-year outcomes, it's always very fascinating for me to kind of see that, because we know that the reported incidence of anxiety, depression, and PTSD is about 60% for all comers with prolonged ICU stays. So these numbers are much, much lower than that has been described in all the other aspects of critical care literature. So it's always interesting. And in our experience with Mani's post ECMO clinic, those rates are very high. So I think like this is, again, there is a degree of selection bias in terms of how they are really selecting these patients and then kind of reporting all of this. That definitely becomes a bit of a interesting point that we need to be thoughtful about.
One other aspect that I was going to hope to touch on is in the setting of patients who say they do have sort of high output septic features and you're just having trouble keeping up with them from a flow standpoint. We've had patients here where we've talked about all kinds of different things in terms of, adding, a complete second circuit in as well. And thankfully, we've never quite come to that. There's been reports in terms of people who do have that high output septic state going from peripheral straight to sort of central VA ECMO just to try to do their best to keep up with the distributive shock aspect of it. And that seems to be a much different population than the one we're talking about here, where it seems to be more cardiomyopathy sort of driving the process. But I was kind of curious, I see we have Nico Brosi online as well. I'm just curious what your guys' approach is to those patients who need more flow and you're having trouble keeping up with, good cannulas and sort of a standard circuit. Sorry to sneak attack you, Nico, if you're there.
I suspect he's probably going to suggest a second drainage cannula.
No, it's one of these interesting things here is that, once you have kind of big drainage cannulas, sort of VV-A kind of thing, then if you're still running into trouble, then that kind of leaves you with sort of unique configuration options in a patient who's already critically ill. And that's why I think sort of the earlier conversation about trying to make the best diagnosis with the best information and have your first configuration being your best one, and then try not to miss that therapeutic window, that sort of like golden window of opportunity where the patient has yet to feel the full effects of all of, the sepsis, the cardiomyopathy, and try to get them, in the point where they still have the resiliency to bounce back.
So going back to Sam's initial question, 27-year-old comes in, septic shock, MSSA, now has an ejection fraction of 5 to 10%. What else would people want to know or would expect, like if you were taking a call for putting this patient on ECMO, like what else based on all the discussion that we've just had? What do people feel? One of our fellows, do you guys want to take this and help us out?
I see Denise, I see Stephen. Who else is there?
Hi, this is Ahmed. I'm one of the first-year fellows. I guess I want to know the cardiac output as well. I mean, the fact that the EF is low doesn't necessarily mean that we're still not dealing with some form of a hyperdynamic situation. The other thing would obviously be the lung status as well. Does the patient have ARDS as well or not? How severe is it? I don't know. These are the things that kind of pop up to my mind. Obviously, beside the comorbidities and everything.
And those are things that we need to think about. I think Penny and Alex bring about really excellent points about this being a multidisciplinary approach, and then really deciding about these things before we kind of think about putting these patients on ECLS therapy. I think having more information and not being reactionary is really important. And what Alex said about choosing the right configuration for these patients is extremely important, and it needs to be discussed in a way that we're not causing harm, or we're not causing things where now we're having to go in and reconfigure things in a few hours because we didn't think things through. And I think that becomes a very important aspect for us to think about.
Hi, this is Denise. Can you hear me? Sorry, I'm driving.
Yes, Denise, go ahead.
Yes.
Yeah, one of the other things I would think about too is, these young patients, we want to fight for them, but also what's our exit strategy, especially when we're putting them on, Ecmo, like are they candidates? And so the extent of organ damage is important because that, may prevent them from being, a bridge to recovery or a bridge to transplant. So these things sometimes, when you get these calls overnight, is also important in my mind.
Great point, Denise. I think far too often we get patients who are committed to something without an exit strategy. So that has to be your thought absolutely before you actually even put the patient on is what am I bridging to and how am I going to get them out of this? I think the other things just to round that out that you want to make sure that you're hearing about, especially in patients who've had any kind of downtime, is what's their neurologic status? When do you last have a neuro exam on them? And just to some of the other things that your other colleagues said about, what's the degree of other multi-system organ failure? So how many, strikes are against us already? And that kind of also speaks to a little bit about, an overlap between cardiogenic and septic shock in terms of vasoplegia, and how far down the pathway are you in terms of this kind of systemic vasodilatory response, and how much do you think you can pull back from it just by providing cardiac support, which might not be enough.
And to
Yeah,
kind
and
of
there's actually a reason I chose this case, because what ended up happening, so despite the shock delivery, he also had DIC and AKI. He ended up coding for approximately 60 minutes and was still put on VA ECMO, and actually had a very poor outcome. Didn't last more than 2 or 3 days afterwards. So that was kind of my,
And what I was going to add, and thank you for emphasizing that, because especially at places like Cleveland Clinic or big tertiary quaternary care centers, you're sort of the last stop for people, and it's always hard to say no. But as we've all seen, there are definitely some things that are worse than death, and you can say no to a situation such as that. But that's why it's even better to have a multidisciplinary team, that you're not making that decision on your own. You kind of take some of the emotion out of it, try to be as objective as possible, and just explain to whoever you can that, this is beyond what we can have. And rather than put them through some terrible course where they're ultimately going to die or worse, being able to say no with the team behind you, I think is a good thing to try to emphasize.
I think we've got a couple questions in the chat. I see a question from Ryota who asks about any thoughts on Impella or intra-aortic balloon pump for severe sepsis-induced cardiomyopathy. I know Dr. Alvarez is on. Paulino, do you want to speak to that?
Yeah, I think it's what in this context, I think this careful monitoring for LV distension, trying to use hemodynamic data, keep an eye on by daily echo monitoring of the aortic valve opening. And I think those are the practical considerations, and I think if you see a distended LV and you know that you're going to be using ECMO peripherally, that's going to, I think, although retrospective analysis have shown that this is kind of the way to go to unload. Which device to use? I think I will say use what you can, but I think if you're, I think the tendency right now is to more efficient unloading going through ECPella strategy. So I think that's one thing, but you can start by balloon pump and see if that is sufficient to allow aortic valve opening and unloading. I hope this is useful. Any comments?
Yeah. If I can add to that as well, I would just say that if you've got a patient who's got severe metabolic derangement in terms of, abnormal acid-base status, then probably you're moving towards VA ECMO support. If you're, worried about oxygenation and whatnot, that's probably where you're headed. If you've got a little bit of wiggle room where you've got a patient on inotropic support, and you think you've got more of an isolated cardiac problem, then you might be able to consider, other percutaneous devices. And then device selection, again, I think is going to be in concert probably with a cardiologist or somebody who knows the degree about temporary MCS, about which device is going to supply you with what, if you're going to get, half a liter of a liter support from an intra-aortic balloon pump versus 2.5 or 5.5 with an Impella. And then what your center allows you to have in terms of expertise and what devices are available to you at hand.
Got it. Thank you.
I would make Ryota, were you going to say something?
No, I was going to say thank you. Got it. Yeah.
So one comment I would make is, and I think we need to think about this as we kind of talk about sepsis-induced cardiomyopathy, is like we should think about how, we've established VV ECMO through different RCTs to the point of Eolia. And one of the key factors that Eolia has taught us is that, you want to have a common language in terms of how you treat your disease process, and you need to do specific things in a very sequential manner. And once you've achieved either success or failure, then move on to the next level. And then when they did that, like basically they were able to choose a pretty good cohort of patients that were placed on VV ECMO for ARDS. So I think when we think about these patients with septic shock, we have to think about all the factors we've already discussed, but we need to go through those things in our mind and really be ready, like if before we pull the trigger for extracorporeal support, that we have answered those questions. And if they are not making sense, or we know that our trajectory is going a different way, then we need to be cognizant enough that like there's not a lot of data for those patients, and then we can't use a study such as this to make decisions for putting patients on when we've not addressed those factors.
Agreed. I think it's extremely difficult to think about how to organize a trial in that setting, about how you might approach it. Abby, you probably have a better kind of global picture about how to approach something like that. But, I think just the heterogeneity of the population, thinking about how you escalate based on, what type of sepsis, what's your source. I can't find a way that I would think I would ever be satisfied with the data than to start making decisions based on it.
Yeah, I think this is one of those things where, you don't think about a trial. You think about a process of care, and you think about developing like triggers and then getting a multidisciplinary team together. I think that's the only way to really do it the right way.
Hi, this is Bala. I think agree with everything that's said. Its point is to have a right care for the right patient at the right time, meaning, if somebody with a low EF, young patient, reasonable lactate, not multi-organ failure, and you have all the data you need, and then maybe ECMO at that time may make sense. Or if you need a VVA or VAV at that time, it's appropriate to decide. I don't think we can ever have a trial like Eolia in sepsis with such a heterogeneity and with different organs being affected. And our experience with VA ECMO and septic shocks has been very, the outcomes have been poor, and we don't have a lot of numbers to go by also. I think this just confirms what, the practice we do. If you have a young patient in our ICU with septic shock who is deteriorating, we may offer him a VA ECMO. But at the same time, if a same patient is referred from an outside hospital, we would probably not take that patient. So that kind of tells you how different the care is and how we approach things. I think overall, this study doesn't change what we do, but at least reinforces that if somebody's EF is low and in early phase of sepsis, may consider a VA ECMO.
Agreed. Thanks, Bala.
I think you bring up a lot of good points, Bala, and really it's this thing, having the patient from sort of initial admission, seeing them progress to sepsis, and having all of your own data in order to make that difficult decision to commit someone to ECLS is definitely one thing, but then hearing about a patient on the phone from other center is a whole other sort of, can of worms there, not knowing exactly what's going on and those sorts of things. So it's definitely more challenging, and we've all been there, accepting these patients from other hospitals already committed to ECLS and finding not what you expected. So that's, those are two situations that I think we've all basically have to face before, but definitely our own internal data would suggest that ECLS for sepsis is something we do very rarely. I think mostly because we're so good at treating sepsis and cardiomyopathy, secondary sepsis in other ways before they get to the point where they were even considered for ECLS. But that's sort of my bias on things.
Agreed. I think
Just
we're
curious,
almost,
what was the median duration of ECMO support between survivors and non-survivors? I might have missed that.
It looks like 6.2 in survivors, 5.2 days in non-survivors.
Okay, so it's not much different.
I'm not sure if they're only referring to the VA ECMO portion of it, though, because a significant number of patients, again, went on to require VV ECMO, presumably for more prolonged periods of time. I mean, that seems relatively short overall.
any final thoughts from our two panelists before we wrap up? Thank you very much to Dr. Duggal and Dr. Wiles for hosting us today and for fostering a good discussion.
I think thank you for inviting us to do this. This is, like everyone said, this is a very complex thing. Like the clinical decision making for this is always going to be very challenging. One thing that does help is being preemptive and thinking about these things rather than waiting like the last moment where you get being called because a patient's peri-arrest. I think everyone's decision making gets changed because of that. So if you're being mindful and I think dynamic assessments early on and adequate supportive conventional care early on are the key things. And once you identify people and then start thinking about this in the right way, perhaps will change the outcomes in very selected individuals who meet the right criteria.
Yeah, absolutely. I think determining at which point you're considering putting them on ECMO if you're going to use it in sepsis, what dose of vasopressor, what lactator, what type of end organ dysfunction, and then also being able as, Dr. Briviesco mentioned, to step back and say that there are worse things than putting this patient on ECMO, even if it is resulting in death, because, this case actually had a very, very, very poor outcome, and I think he suffered probably longer than he needed.
Exactly, and what I would just add as well is that what I tell all the patients and their families before committing them to ECLS is that, ECMO ECLS doesn't actually treat the underlying cause. It basically supports the organs to allow us to figure out, what's going on and treat the actual issue, be it, source control, being allow the cardiomyopathy to recover, and ARDS letting the lungs to recover. And so knowing that, you have to be very thoughtful about putting someone on ECMO when you're not sure if it's sepsis or cardiomyopathy, because you don't really know where that ECMO is going to take you. And as Denise brought up, astutely so, you have to have an exit strategy when you commit someone to ECLS. So.
Okay. All right. Any other questions? Any comments?
Okay. Think we're good. Thank you again to our speakers, Dr. Duggal, Dr. Wiles. Thank you to everyone who joined us. Again, this is being recorded and will be available via YouTube on our YouTube channel. We'll send out the links again to that. I don't know if you're able to put up that slide again, Donna, just so that they can see it as we're all logging off here. Thanks again. Be sure to claim your CME credit, and we'll let you know when our next one is in about 2 months. We'll send out the topic and the journal articles ahead of time and hope to see you all then.
Thank you, everyone.